All right, so we're going to go over chapter 34, which is all about traumatic brain injuries. All right, so we're going to talk about the difference here between what an acquired brain injury or an ABI and a traumatic brain injury is, a TBI. Really, there's not a massive difference. ABI encompasses the definition of TBI. Okay, the difference is, when it happened. A TBI is any kind of insult or injury to the brain from an external source. Okay. Some examples of TBIs are CVAs, so strokes, any type of a brain illness or infection, any kind of brain injury acquired after birth is considered a TBI. Car wrecks, football injuries, anything like that any type of injury acquired after birth to the brain is considered a traumatic brain injury. There are different levels of TBIs. There's a mild form. What I want you to remember with mild forms is it's like a concussion. Okay, a concussion would be a mild TBI. A moderate TBI goes up in severity by you lose consciousness for at least 30 minutes, lasting up to 24 hours. Okay, so you definitely want to know that. And you can have a skull fracture with a moderate TBI. 30 minutes to 24 hours and can include a skull fracture. Okay. And then a severe TBI. This is a loss of consciousness for more than 24 hours. And the patient has memory loss after, they wake up. Okay. Even somebody that has like a mild TBI can have life-changing effects, memory loss, trouble paying attention, all of these kind of things. Even with one concussion, multiple concussions back to back, is going to result in a much, more severe outcome. You'll hear a lot of, ex-NFL players or college football players that have had multiple concussions are a huge risk for developing dementia and Alzheimer's disease at a much, much greater risk. There's one disorder, I can't remember the name of it off the top of my head, but it looks like Alzheimer's disease and the brain shrinks. Anybody knows what that is? Have you ever heard of that?
Is that the one that Aaron Hernandez had?
Yes. What is the name of that? A guy that was in my class did a report on that when I was in school. I can't remember the name of it, but anyway, it's specific to football injuries and multiple concussions. So there's a couple of other things that we need to define. CTV. Yep, that's it. I forgot where. Is a vegetative state. If somebody is defined as a vegetative state, that means they have no awareness and no responsiveness. There's nothing there. Okay. There's a couple different types of injuries that we need to talk about too. There's one called diffuse axonal injury, or DAIs. These happen in about half of all severe head traumas, and it's one of the most common forms of TBIs. And what it is an injury over a more widespread area. Okay. It is the leading cause of death in people with traumatic brain injuries. The next one is an axonic brain injury. This is where that hypoxia comes into play. Does anybody remember that term from the CVA chapter? What does hypoxia mean? So I told you there are three types of strokes. There was the ischemic, hemorrhagic, and hypoxic. What was the hypoxic stroke?
Not getting air to breathe.
Right, when you're not getting oxygen, right, through breathing. So breaking that down a little bit further, just so you guys know a timeline, after about 4 minutes of significantly low oxygen levels, the brain cells begin to die. After 5 minutes, the injury is permanent. Okay. It's extreme when someone is not getting oxygen, like from CO2 poisoning or something of that nature, right? They're just being cut off oxygen supply. That is really, really dangerous and is really, a serious thing. It will start to kill brain cells, like I said, in 4 minutes, and after 5, it's like irreversible. It's permanent damage. Okay. We're going to go over a couple scales today. The first one is the Glasgow Coma Scale. Don't worry about writing that down about that yet. We're going to go over the stages of it. But first off, does everybody know kind of what a coma looks like? How would you describe it, Maggie? A long sleep. Okay. So with people with comas, do they wake up and then go back to sleep? No. So what a coma is a loss of the sleep-wake cycle. Okay, that's how it's defined. There's no wake cycle in it all. It's all sleep cycle. Why do you think a body goes into a coma, Jennifer? Okay. What would your body be defending against in a coma? Do you just randomly go into a coma? Okay. Right, they can do medical induced, but that's when we just keep somebody under in sleep so they don't, pull out a ventilator and stuff like that. What, Allie, what is the biological benefit of a coma? What is your body doing? What do you think, Isaiah? Resting.
Body's trying to slow down and semi-shut down processes.
Okay. So what is your body doing in a coma then? It's repairing. It's going back to the most basic functions, right? You're breathing and you're sleeping, right? It's just doing the very basic necessities to keep your body alive so it can focus on healing. A lot of times that's why they'll put patients in medical induced comas, because their body needs healed, or like I said, they're at high risk. They'll wake up, rip a ventilator out, stuff like that. They don't keep patients awake while they're on ventilators, because if they do, think about it, it's going down their throat. That's super uncomfortable. You're going to rip it out, right? And it freaks patients out. All right, so let's go to page 889 in your book. We're going to go over first the Glasgow Coma Scale. And then one of my favorite words in all of this, our favorite terms, is the Ranchos Los Amigos Scale.
Ranchos Los Amigos.
Yeah, it is. These are the levels of cognitive functioning, okay? This is how we scale our treatment with traumatic brain injuries, including strokes. I said with my dad, how his was totally different than everybody else. He had no physical deficits. So when I was going through treatment with him, he followed these Rancho scales to a T. I could name a behavior in each level that he did, and you can watch him all the way up to where he is now. And it's pretty much picture perfect. I'm going to show you what this Glasgow scale. First, this guy is going to teach you what the scale looks like, okay? And then I'm going to show you, or going to tell you what the scale is, how it is used. Second video I'm going to show you is these students actually, they act out what the levels look like, okay?
Today we're going to show you a practical way to perform one of the most important parts of the neurological assessment, the Glasgow Coma Scale. If you want to learn about all things neurosurgery, don't forget to subscribe to the Brain Book channel. The Glasgow Coma Scale was developed in 1974 by Graham Teasdale and Brian Jeanette. Every neurosurgeon will use it to assess a patient's conscious level, whether it's after an acute brain injury or if they're monitoring a patient in the intensive care unit. We've got the awesome CMO here with us today who's going to be our patient, and I'll show you how to do this quickly and easily. When you approach the patient at the bedside, you can get a lot of information about what to expect. If you're in an intensive care unit and the patient is intubated, for example, they may have drugs on board that are going to affect the GCS scale. If you're seeing a patient on a Friday night who's been attacked outside of a bar, they might have a lot of alcohol on board. This is seriously going to affect your examination, so it's really good to know beforehand. The GCS rates a patient's conscious level according to 3 components: what their eyes are seeing, what they're saying, which is the verbal, and what they can do with their muscles, the motor bit. Each of those components is split into separate criteria. There are 4 for eyes, 5 for verbal, and 6 for the motor score. A normal response is the highest or best number, and the lowest is no response.
Okay.
The best score.
You got that? That the highest is the best, lowest is the worst, okay? And he's getting ready to tell you this, but it's never 0. The lowest in the Glasgow Coma scale is 1, okay?
That you can achieve is 15, and the lowest is 3, not 0, never 0. Walk to the bedside and introduce yourself. Shout if you need to. Sometimes people might have hearing aids that have run out of batteries, or they've had skull fractures causing damage to their ears. Sometimes your patient will already be sitting up with their eyes open, having a cup of tea. If they open their eyes, then that is to sound. You can grab a pen or some kind of blunt instrument and apply pressure to the nail bed, starting slowly and increasing the intensity until they open their eyes or until you put on enough pressure. You need to do this for at least 10 seconds. Remember, you're not trying to hurt them, but you shouldn't be a soft touch. If they open their eyes to pressure, then you say to pressure. So far, not so bad, right? If they don't open their eyes, it's none. Just remember that if both of their eyes are swollen shut from trauma, or a particularly horrendous wasp attack, for example, then you need to say that the eyes are not testable, or NT. Next, we're going to assess the verbal response. You don't need to go into a full AMTS, but just start talking to them, ask them if they know what their name is, where they are, and what month it is. If they get all of that right, then they're orientated. If they're not orientated and they're speaking in phrases or relatively complete sentences, then you can mark them down as confused. If they're talking gibberish, single words, most often swearing at you, that's words. If they're moaning or groaning and you can't make out what they're saying, then that's sounds. Things are starting to get a bit concerning by this point. If they've got a tube down their throat helping them breathe, it's kind of not testable, so put down NT. When you're testing the motor score, you need to ask your patient to perform a 2-step action, either grasping and releasing your fingers or opening a mouth and sticking out their tongue. If they can do that, they are obeying commands. You cannot use the peripheral stimulus alone to test the motor response, so you need to do something called a central stimulus. The first thing that we're going to show you is the trapezius pinch. Here, squeeze for up to 10 seconds and assess what their best response is. If the trapezius is not giving you any response, then you need to go to the supraorbital notch and use your thumb. Again, do this for 10 seconds and get the best response. If they move their arm or hand up above the clavicle towards the stimulus, that's localizing to pain. If the arm bends and moves rapidly away from the body and the stimulus, that's normal flexion. Abnormal flexion is when the elbow bends slowly and the arm comes across the body. Extension is when the elbows start to extend, and that's again a really bad sign. And if they're paralyzed, always put it down as NT. And remember to always make sure that you get the best response. Hopefully you enjoyed that video and you find it really useful.
Okay, so did you guys follow along with that table on 889 as he went through? Does that make sense? It's pretty self-explanatory. It's just routine practice of how to do it. Pretty straightforward. Cool. So why is that important? If you go in, especially in the acute care setting, and you see a patient and they say that they're, this level on the Glasgow Coma scale, you need to know what that looks like, right? So you can gauge your treatment. If somebody is, even at the higher levels on the Glasgow Coma scale and they're, not having a lot of appropriate responses, they may have some response, but some appropriate. What do you think occupational therapy is doing with those patients? Right, range of motion and positioning. That's two extremely important. You don't know how long that this coma state is going to be, lasting, right? So if they're laying in a bed for an extended period of time, they're at huge risk for pressure ulcers. So proper positioning, range of motion to make sure that their joints don't get stiff. And I know that that's, sounds boring or, not true OT, but I'm telling you, that is so, so important. If these people don't have their joints moved, I mean, you're up a whole heap of trouble when they get better, right? When they come out of this and say that they didn't have a frozen shoulder when they went in, now they're trying to fight off, whatever TBI that they are going through. And then on top of that, they have a frozen shoulder. That's something you don't want to deal with. A lot of things post, TBI can be avoided if the proper treatment would be done in hospitals. I kind of have talked to you guys a little bit about that one patient I had who had COVID, was on a ventilator in a medically induced coma, and they put him all sprawled out, right, and had a brachial plexus injury. If they would have properly positioned his arms, that would have never happened. And now his, right arm was paralyzed for, I don't know if it ever did get better. He had a little bit of finger flexion, a little bit of wrist flexion by the time that I was done with him, but, and he got moved to another person's caseload, but that was, as far as I could get him. And that injury could have been prevented if proper range of motion and positioning would have been done. It's one of the most important things you do in acute care, because, I mean, you're preventing huge injuries and huge illnesses from happening. So don't downplay range of motion or positioning. I know we kind of use it as a cop-out answer every now and again, but it's so important, especially with TBIs. All right, so we're going to go over these Rancho's Los Amigos scales, or the levels of cognitive functioning, one by one, okay? You guys can follow along either in your book. If you want to look at page 889 on table 34.2, we're going to go over each one of these levels and what they look like. Like I said, I've experienced these very personally with my dad. I watched him go through each level, literally picture perfect, exactly the way your book describes it, okay? All right, so for Rancho level 1, this is classified as no response, okay? This person is not responding at all to external stimulation, and is likely in acute care or an ICU. In this area, we're going to be focusing a lot on positioning and passive range of motion. Again, positioning is super crucial to prevent pressure ulcers. Passive range of motion to keep the joints mobile. At this point, too, it's important, and this step often gets forgotten, to teach family members passive range of motion and what that looks like and how to do it properly, because, they're going to be, hopefully, in COVID world, who knows, but hopefully they're going to be bedside with them a lot, and they can be moving their arms and moving their joints way more than what you're going to be able to get a nurse or a CNA to do, because they're with them all the time, right? With passive range of motion, really, there's not an overdoing it. Like, you can overstretch it, but you want to keep moving the arm, do it all as much as you feel like you want to. The more the merrier is what I tell family members. You got to keep that joint mobile. You may also work with the patient on orthotics and trying to prevent contractures or anything from like that getting tight. That's another thing you might do. Level 1's pretty straightforward. Are we good with that one? Kind of know what it looks like. Like I said, I got good videos for all of these too. All right, so level 2. This is characterized as generalized response. This is where the patient starts to react to stimulation, but it's inconsistent and non-specific. There's not really a purpose to the response, and they can still be considered in a vegetative state. So what might this kind of look like is on the Glasgow Coma Scale if you're going to compare them side by side. So they're reacting to stimuli, but it's not specific. It's not like a correct response. There's just a reaction. You could make a case for a couple of them, but where's your level of thinking at? Okay, so what would that be on the motor response for the Glasgow scale? Go to 889. It'll help. Someone want to help her out? Okay, So what level is that at for motor response? Very good. So let's say that you did some type of stimulation. They started like moaning or groaning. Not really a word, but motor or groan. What would that be, Isaiah? Very good. And then their eyes just open. Maggie, what would that one be? You did some type of an external stimulation. Their eyes just open and then they shut back. Very good. Does that make sense on how those correlate? Good deal. All right, so this patient is probably going to be in an acute care hospital. Very, very rarely they might be put into an inpatient rehab, but probably not at a level 2, unless it's something that they think they're going to see for a while. Okay. Again, we're going to be doing positioning, passive range of motion, orthotics, sensory stimulation a little bit, and family education. Again, the primary goal of using an orthotic here is to put the hand in like a functional position to prevent contractures. All of that good stuff. Any questions on level 2? Everybody kind of knows what it looks like? All right. Level 3. This is characterized as a localized response, okay? This is where the patient starts to respond to stimuli in a specific manner. The response might be delayed, but regardless, there is a response and it's specific. These patients are going to be in an acute care hospital or an inpatient rehab facility. A lot of times patients at a level 3, you're going to see an increased tone. And so we're going to be still focusing, even at level 3, on positioning and orthotics, okay? One of the big things you're introducing in level 3 is some more sensory stimulation, okay, from all different areas. You're going to be doing, as far as like smells, this is where you might have a family member bring in a familiar bar of soap. If they were somebody that liked Irish Spring all of their life, they bring in Irish Spring to do their bedside bath. You want familiar things, okay? Things that the brain can recognize pretty quick. You may have their favorite candle, something like that, okay? You're trying to make this hospital room or inpatient rehab facility room as familiar as possible, okay? You may even have them do take home and wash their clothes in familiar stuff. If you've always used Tide or Gain or something like that, a familiar scent, you may take home their gowns or whatever the hospital will allow you, and you take it home and wash it in that type of detergent. So that is another sensory stimulation. Okay. As far as gustatory, like their taste, you may do something familiar like a lemon swab, okay? Everybody kind of knows what a lemon tastes like, right? Super sour. It's a very familiar thing. Now, you don't want to start giving them their favorite foods at this point because you don't know if their swallowing has been impacted by the TBI. Always talk to the speech therapist or the physician about like if they have swallowing issues to make sure that they're cleared to do other things. But you can at the lowest level, you could swab the inside of their mouth with a lemon swab, okay, which all hospitals and facilities have. If you want to throw some temperature in there, you could freeze the lemon swab and put it on the inside, you know, kind of like a lemon popsicle. Does anybody know, do you know what I'm talking about when I say lemon swab? It looks like a big Q-tip. Some of them look like a mini long-handled sponge. They have a little itty-bitty sponge on the end of it, and it has a little bit of lemon flavor on it. Traditionally, though, you see the ones that are wet and are like long cotton swabs, and you just rub it on the inside of their mouth, on their tongue, because that's a familiar sensory stimulation activity, okay? Are we good with that one? All right. The next one would be auditory. This is where you're going to have them bring in the family familiar music, okay? You want to keep it down. You don't want it to be super noisy. You don't want it to be overstimulating, but if they are somebody who really loved 90s country music, have them play 90s country music in their room, okay? Something that is familiar to them. You're going back to try to unlock, if it makes sense to you, like core memory stuff, okay? Things that they're going to be able to recognize without having to do a whole lot of effort. You may even sing with the patient. A lot of times in acute care, you may have like especially in this area, a hymnal book or something and sing like old hymns with patients while they're at their bedside. That kind of stuff is, huh?
You do that?
Yeah,
You do that?
yeah, absolutely. You don't think I can sing, Jennifer? I hate that. Yeah, absolutely. And it doesn't have to be a performance. I mean, I'm not going like full, Baptist choir, but, just sitting there singing like Amazing Grace with the patient at their bedside. Just hearing, a familiar song and encouraging the patient to sing along with you. That kind of stuff. Very basic kind of core memory stuff. Okay. The next one is visual. Keeping things in their room that is familiar. They're a common household throw, like if they had a favorite blanket at home. Clothes that they really liked to wear. Okay. Pictures of family members and pets and friends, not distant people. You want close people at first. When my dad was at this level, I would go through and I would show him pictures of our family and make him name something about us. Like, okay, that's my brother Tyler. Tell me something you remember about Tyler, and go through it with him, right? And talk to him about that memory. How well can he remember? Make him recall. He might get some things wrong. That's cool at this level, okay? You just want him responding as much as he can, trying his best to remember. Now, you don't think this sounds like a whole lot of effort, but patients at this level, even with doing a little bit of memory activity like that, that's going to wear them out. After I would do a memory activity with my dad, he would sleep for 3 and 4 hours. I mean, it would just absolutely wipe him out doing something very basic like that. But it really helped him. It really helped him to remember people's faces and all that stuff. There's a couple of things that you might see with TBIs. We've talked about them before. Diplopia. You guys remember what that was? Diplopia? God, I can't say it again. I'm not going to. It's double vision. Remember that from the vision lecture. And then hymenopsia. What was that one? That's half of the vision field is gone, right? Right. So one thing you may do is encourage the patient to look to both sides and put sensory, like visual stimulation on both sides. So if you're going to bring in pictures of family members, put some on the left and on the right side so they have to look side to side. One thing that my dad had a lot of trouble with was visually focusing. You could look at, and he could not follow your finger. Right. So if you did like the DUI test with him, it wasn't, he could not follow your finger. He could do left, right, up. And then when you went down, right at that breaking point where your eyes would be technically starting to be angling down, he could not do that point. It was the weirdest thing. He could follow you left, right, up. And then when you went down, his eyes would just twitch back and forth right there at that, at the midline. Very strange. But he had a lot of stuff. That turned out to be one of the biggest issues when we were talking about ADLs was his visual scanning. He gets in the shower and, you look down to bathe yourself, right? You look down to grab the bar of soap and whatnot. He wasn't able to do that. So that was one of the biggest hindrances to him being able to do his ADLs. So what we started doing was everything that he did, all of his activities, I would have him sit at a table and I say, okay, you're not allowed to move your chin or move your neck down. You have to move your eyes down to look at our activity, whatever we're doing. Eventually it went away after doing it repetition. Okay. And then the last one is vestibular. It would be good to have patients sitting upright if they're cleared to do so and if they're safe to do so at this point. But any kind of like a balancing activity, very light stuff is okay. As long as the doctor says it's okay. You may have them sit on the side of the bed and play a game of cards. Something low level, maybe not even cards, maybe a coloring sheet. Something low level and sitting up. Okay. Patients are a lot more alert when they're sitting up than if they're laying down. Okay. Same as anybody. I mean, who is more alert when they're laying down? Right? We're all a little less alert when we're laying down than you are sitting up. You just don't have that stimulation coming from all areas. Okay. I know that was a lot for level 3, but there's a huge change in between level 2 and 3. Is there any questions on those two? No? Okay. Let's go to level 4. Level 4 is characterized as confused and agitated response. This is where their behavior might begin to seem bizarre or inappropriate. They're going to have poor attention and poor short-term memory. They may be impulsive, have balance deficits, poor safety awareness, but the big one here is the agitation. They're very agitated. Now, I will say with my dad, and when he went through level 4, his agitation was more of, it was not seen to me as agitated as it was frustrated, because it was almost that he knew his personality was different at this point than what it was before, and he was more frustrated with us having to do all this than it was just simply agitated. Clients who are mobile and are functioning at the level 3 or level 4 may even need requirements or meet requirements for needing restraints, because they may be so agitated that they're pulling out IV lines, they're hurting themselves in some way. It's just not safe. So they may be a candidate for restraints. That's if the facility lets you. Okay. Generally speaking, hospitals will allow restraints because they're whatever's safe for the patient, right? But you're in a inpatient rehab facility like a Genesis or one of those, they're probably not going to let you do that. Even if it would be safer for the patient. They have a no restraint policy. I see why they do that, because it could be overused and lead to utter abuse. But at the same time, if you're dealing with somebody who is at danger of hurting themselves at no fault of their own, it's just where they're at. To me, it's you're not doing what's best for the patient. You may do things that are a little less restricted than like a belt or something, but you may even put like mitts on them so they can't pull out IV lines. It makes it much more difficult for them to do that. At this time too, you need to be concerned about their ADLs and performing ADLs, because they're going to be doing them very unsafely. Okay. Again, they have that impulsivity kind of stuff. You don't want them to be performing ADLs alone. It's hard to predict what they're going to be doing at a level 4. Okay. They kind of, I don't want to downplay it or seem insulting, but a level 4 is almost like a toddler that's mad. Okay. That kind of behavior that's like doing activities, but they're not doing them correctly and they're not doing them safely on purpose because they're mad, right? That kind of a thing. That's the type of behavior that you're seeing at a level 4. You're going to be doing a lot of family education, because at this point, it's very hard to watch a family member go through that. Letting them know that this is a stage of recovery that we're going through is going to be very helpful. Hopefully this will not last forever. Those kind of things. Okay. All right. Any questions on level 4? Are you guys good? Okay. So Rancho's level 5. This is where this is characterized as confused, inappropriate, but a non-agitated response. Okay, the agitation is now gone at level 5. Their memory and attention continues to be impaired, and the client is not able at this point to retain any new information. Okay, I'm going to say that again. The client cannot retain new information at a level 5 yet. Okay. A big issue here is insight. That's one of the biggest reasons you can't do that, because they're not understanding still yet what's going on with them. Okay. At this point, they're probably going to be in an inpatient rehab facility, or with the possibility, like my dad at level 5, he was home with us. They can be discharged at home, but they're not going to be left alone. This is still 24-hour supervision. They're going to have home health, OT services, and PT services, or if the family is able to, take them to outpatient services. But probably home health is the best option at this point. One thing we're going to be working on with a level 5 is orientation. What's the year? What is the time? What's the date? Who's the president? All these types of questions. Have you heard these before in stuff like a lot of times the speech therapist, you'll hear them run through those questions a lot. I can't remember the name of the assessment you guys did last semester in 209 that you guys did that. The mini mental, that was it. That's it. The mini mental. Those kind of things. Thank you. Those types of questions. Kitchen activities are a good way to help starting to address problem solving, attention, sequencing, safety awareness, all that kind of stuff. You don't want them like cooking this huge immaculate meal. What might be something that you would do at this level you think that would be safe? Something that involves sequencing, problem solving skills. What might you do as an intervention, Lindsay? Making a peanut butter sandwich. Okay, there's not a whole lot of, what's something that you can think of that's even lower than that? Bowl of cereal. There's a little bit of sequencing in that. Something even like I use instant pudding is a good one. Cold milk. There's no burning there. Whisk it together. It's pretty much it. Let it sit in the fridge. Okay. There's steps with it, but it's very low level. One of my favorite things that I always kept in my car for home health was those mug cakes that you can buy. They're fairly inexpensive and patients love them, right? I mean, who doesn't love a warm cupcake in a mug, and they do it themselves. There's not a lot, but some steps to it. There's a lot of sequencing to it. But it helps with that reasoning and problem solving stuff. It's set directions that they have to follow. But anything like that, okay? The mug cake might be a little high for a level 5, something more low like the pudding mix or peanut butter sandwich or stuff like that's going to be more appropriate. All right, any questions on level 5s? The big difference between the 4 and 5 is the agitation is gone. Okay, cool. All right, let's talk about level 6. This is where this is characterized as confused and appropriate response. This is where they're going to have difficulties with recent memory, but they're able to use external cues for direction. Okay, they're going to start looking around and using external stuff to help them formulate their answers. Okay, so you may say, what is today's date? And they may look outside and see that like the leaves are on the trees, it's sunny, it's warm outside, and they're going to guess a time in the summer or spring compared to it might be like this outside from one of the lower levels, and they say it's December. You know what I mean? They're starting to use an external cue to formulate their answer. Patients will often do what's called confabulation, which is where they make something up. They make up a story. They may tell you something that's completely not true. Okay? By no fault of their own, their brain is just wanting to make sense of things. Kind of that idea of, have you ever heard of how the stories, no matter even if it's like a core memory of your own, the way you remember a story is probably not the way that it happened? You ever heard that? Like even like you remember your uncle at your 3rd birthday party dressed up as a clown for the party or something like that, right? You may remember that, but actually, he dressed up as a dinosaur or something that was actually. That's kind of what our brains do. It naturally wants to make sense of things. It doesn't like the unknown. So it makes these connections, if they're true or not, very true at a level 6. Okay. They may make something up completely off the wall story, and it's not even close to true. At this level, you're going to help them start to create a daily schedule or a calendar for things. Like what I did with my dad at this level is my mom was still at home with him at a level 6, but we had a dry erase board and we put chores on it every morning that he had to do. He had to do dishes. He had to make breakfast. He had to take a shower. They weren't like huge chores, but it was getting his daily tasks in order, right? Something as very simple as that is really going to help improve someone's independence at a level 6, okay? You're going to start wanting to talk to this patient about safety awareness. You may use cards and things like that, which I will show you the safety awareness cards that we have in the lab. Basically what that is showing them a picture of an unsafe scenario, and they have to tell you why it is unsafe. Like, for example, you may have somebody that is riding a bike without a helmet, and I show it to you, and you have to tell me, why is this picture unsafe? Oh, well, that's because they're not wearing a helmet. Why is not wearing a helmet unsafe? Okay, and they walk you through the steps. Okay, that's a safety awareness card, and we have some over in the lab. I'll show you. At this stage, you may now start introducing adaptive equipment. If they need it, you could do a reacher, elastic shoelaces, a sock aid, stuff like that. You can now start introducing things like that. Things that don't need a lot of training. You know, a reacher doesn't need a lot of training. Elastic shoelaces need no training. They just put on their shoe. You know, very basic stuff, okay, as far as adaptive equipment goes. At this level 2, you're going to do what's called dual task practice. This is where you're doing two things kind of simultaneously without the patient knowing. Instead of having them sit and play a game of cards, you may at this level have them stand up and play a game of cards. So it's kind of like a dynamic standing task and doing some memory, whatever game you're playing. So at this level, you can introduce that stuff. It's not two things that are totally, you know, off the wall, unrelated to each other, but they go cohesive together, like standing and playing a game or standing and cooking a meal and stuff like that. Okay, two skills that are not separated, but you put them into one. Does that make sense? All right. You guys are awful quiet today. You sure there's no questions? Okay. All right, so Ranchos, level 7. This is characterized by an automatic and appropriate response. At this level, the client's behavior is becoming now more appropriate, especially in familiar settings at home, with social groups, those kind of things. Learning, their new learning is becoming more familiar to them. They're starting to get a lot of carryover. It's still slower than what it was before they had the injury, okay? But it is very evident now. You can see that they're learning new skills and becoming more comfortable with them. Their overall judgment still continues to be impaired. At this level, they're probably going to still have a lot of anxiety about making big decisions. They don't, you know, want to pay bills and stuff like that. They don't want to mess it up, things of that nature. You may start introducing, though, money management by way of, you know, sitting with them at the kitchen table and say, okay, pretend that we have gone out for a meal. Okay, here's your menu. Choose what you want. Okay, and then have them count out money to pay you. Okay, have them walk through that. You role play with them, walk through that scenario. Oftentimes, I'll take patients at this level to do groups with other patients because it's really good to have that social interaction with other people to learn the norms. Again, what you say, what you don't say, the normalcy of, hey, how you doing? Those kind of things. Normal actions, okay? At this level, it's definitely appropriate to do with them. Any questions on that level? All right, let's talk about the last one. This is Ranchos level 8. This is purposeful and appropriate response. At this level, this is where the responses are now appropriate with whatever scenario that we're going through. Okay. At this time, they're oriented to the place where they're at, time, all of that stuff. Their abstract reasoning, like really thinking outside of the box, using logic, stuff like that, is a little bit still too far outside, and that's still the case for my dad today. He has terrible time management skills. You know, if he has 4 hours or something before he has to go to work, he feels like he has no time. He can't go to the grocery store for a 30-minute run, go pick up some bread. Like, that is mind-blowing to him. He freaks out. He cannot take it if somebody is, you know, asking something, especially on days that he goes to work. He can't take that. The logicness of understanding time, and, you know, 4 hours is plenty of time to run to the store and get milk and eggs and come back, and you'll still have 2.5 hours, 3 hours. That kind of abstract reasoning is still beyond my dad, and it's been 4 years. So he gets a little better day by day, good days and bad days kind of stuff. But for the most part, I would still characterize him at a level 8. Okay. The focus of rehab is, at this point, is really just maximizing their skills, getting them back to their maximum level of independence. One thing that you guys have not heard me say this whole time was timelines. Like, how long do these levels last? That's different for each person, okay? Some people don't go all the way through to a level 8. Some people stay at one level, which is very scary. Okay, this isn't always a continuum. Okay, a lot of times it is. They get up and you can finally get them to some form of independence as it was before. But a lot of patients don't get that far. Okay. The last thing I want to mention about level 8 is exercise is really good, as it is with all brain injuries and stuff. I've talked to you about dementia, Alzheimer's, and, strokes, all that. Exercise is good. It gets blood flowing to the brain. They get better oxygenated blood. I'll tell you this, and this is just my personal opinion. I think exercise is one of the best keys to treating brain injuries. And any experience with my dad, if he has used his brain, like if he has gone, he's a toll collector on the turnpike, and if he has used his brain and counted money and stuff all day, when he comes home, you would never in a million years know that he had any type of brain injury, like none. He's completely normal, personality's the same, everything. On his days off, those are his worst days because he likes to watch TV. He's not really a big outdoorsy person. He doesn't do that. What we did to make the difference up was we got him a gym subscription. He goes to the gym on his days off in the morning to get himself going, get the blood pumping, and it drastically changes his personality and independence in a day. Totally different person whenever he's used his brain, done any kind of activity at all to use his brain and get any kind of movement. Okay? Any questions on those levels? You need to know those like the back of your hand. Okay, they're very important.
For all those levels, can somebody be awake, or are they they can be awake for every single one of them?
Not level 1.
Okay.
Not really level 1. It's level 1 kind of looks like the coma scale around the 2-ish, but they make that huge jump between 1 and 2 that it's not really asleep. It's just they're there but not kind of thing. And there's a really good video I have that will show you what each one of those levels look like. Okay. All right. So what's the impact on the client and family? At this stage, patients are completely different people. Like I said, I know this very, very personally and how hard it is for the family to go through something like that. They have memory deficits. How hard would it be for somebody to look at you and say that, they've been married to you for 35, 40 years. And then they look at you and say they can't remember their wedding anniversary, or they don't know how long you've been married. They know your name, but they don't really know that you're their wife or husband or whatever. Those types of things are what family members are going through with a TBI. To not recognize close friends or family members or pets or anything like that. It's very difficult. But at this point, the beginning stages on these scales, it's important that you involve the family members in treatment as much as possible. Okay. Teach them passive range of motion and positioning. Teach them, what does typical recovery kind of look like? That's hard to do because it's different. Everybody's totally different with TBIs. They recover at different levels, and sometimes they recover fully, sometimes they don't. It really is just all over the place. But reassuring them and giving them helpful tips. The morning after my dad's TBI, when he woke up, I had him get up. I had him brushing his teeth. I had him doing as much normal stuff as I could. I had him playing cards on the side of the bed. I had him looking through familiar family members' pictures. All of these things, pretty much immediate. That's why I think my dad had a pretty decent recovery, is because it started immediately. A lot of people don't get that. A lot of people don't have that education behind it. I mean, my mom's been a nurse for 34, 35 years, and I had been practicing for 2 years at that point. So, how much better of a team was it to take care of somebody? But, I've said it several times, if he didn't have that type of support at home, I don't know what his recovery could have been like. So I'm pretty passionate about educating family members in those moments, in those acute care hospital moments, about how important it is that you are constantly working with them. Okay. Teaching them what the normal behaviors are. They get to that level 4 agitated stage. They're not mad at you. That's a normal stage of this recovery. Okay. They're irritated. They're not happy with what's going on. Their brain wants to make connections that it can't. It's injured. But letting them know there is a level 5 where that goes away. One thing to remember that I kind of did not mention was 2/3 of individuals with TBIs have history of alcohol abuse. That's just statistically speaking, which can be a huge problem with TBI recovery because you're already dealing with somebody who has poor memory, poor judgment, and then you throw alcohol on top of it. It really is, it's a bad case scenario.
They develop an alcohol.
No, they had alcohol abuse. They had alcohol abuse.
Why is there such a strong correlation?
You know, I don't really know. One thing, I really don't know what the strong correlation would be. Now, a lot of them, I don't know statistically speaking what it is. I think it's roughly 2/3 too of people post TBIs develop alcohol abuse too. But yeah, because of depression and stuff like that. But the other thing, which is kind of uncomfortable to, talk about with patients at this point too, is that TBIs drastically affect sexual activity and sexual arousal. And you have to kind of address that from step 1 too. The loss of pleasure, the loss of, that feeling or needing of intimacy, that kind of comes along with TBIs. It changes the person's personality, like their sex drive kind of disappears. Their brain isn't at that stage. It's more of a healing stage of trying to return to normalcy than it is, that kind of thinking. So you may need to address that with a family member too, when you're, especially in the acute care hospital setting. Okay. All right. Are there any questions or are we good? All right. We're going to do this knowledge assessment together. Okay. And then we're going to do some videos. So now that we've gone through this chapter, match the descriptions with their Rancho scales, levels 3 to 8. I'm going to go ahead and stop the recording.